All right, good afternoon or morning, depending on your time zone, and welcome to today's webinar entitled Understanding the Coding Nuances for COVID-19. We appreciate you taking time out of your very busy schedules to join us for this 30-minute web session. Let's cover a few housekeeping items before we begin. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of your questions live, but we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented and a link to the live recording within 5 business days. May I reiterate, you will be receiving an email within 5 business days with today's presentation, a link to the live recording, as well as an FAQ document with the questions and answers received throughout today's session. Today's presenter is Jennifer Bishop, Vice President of Content here at VitalWare. Jennifer, the show is yours. You now have the floor.
All right, thank you so much, Julie, and welcome everybody. I hope everybody's staying safe, and I have emptied out my house today. Everybody's outside, but I am at home, as I'm sure a lot of you are, so please bear with me if there happen to be any kind of technical issues. I don't anticipate any, but here's hoping. All right, so quick little disclaimer there that anything that's in this is likely to be outdated by the time we finish the presentation, as things are changing so rapidly in this particular pandemic. But this is the best information we have at this particular time. So I thought I would throw a screenshot in here for a couple of reasons. This Johns Hopkins website is the best place to check for the daily statistics. It is not going to contain any malware or any other kind of bad things that could happen to your computer, and it is the official total. I put this on there late yesterday afternoon, and again, I'll guarantee this is probably out of date. I know it's out of date at this point, but that is a good place to check stuff. All right,
Jennifer,
yes.
Jennifer, I'm going to interrupt you real quickly. Your screen is not changing slides.
Sorry.
There you go. Perfect.
It is on my end. Thank you so much.
We're seeing the disclaimer.
There's our disclaimer.
Right,
okay, sorry, there's our Johns Hopkins websites, our cases that are or were current as of yesterday afternoon. 10/14 yesterday is the last time that was updated. Thank you for that, Julie. All right, so we have lots of cooperating parties that have come together to release guidelines, new codes, FAQs, all kinds of stuff. So I put those up there, all good places, all good sources of information. And we're going to go through and talk about this in a couple of ways. We're going to start talking about the diagnosis code changes, and then we'll talk about the particular CPT and HICS code changes for billing the test. So let's start with the ICD-10. Need a little bit of humor during all of this. So we had supplemental guidelines that were released on February 20th, and they are effective as of February 20th. I expect those to be updated again because that was prior to release of the new ICD-10 code. We have a new code for coronavirus that is to be effective April 1st. So I also wanted to highlight that as we go through here. There's different coding instructions for reporting this today than there will be on April 1st. So I have highlighted in the presentation the April 1st guidelines, but we're also going to go over how you actually code this today. All right, we will, I'm sure, be getting new codes and coding guidelines updated for October 1st or fiscal year 2021. And this does require other codes to fully code all the scenarios, but we're not going to replace any of the previously released guidelines. This actually just builds onto our previous guidelines. All right, so let's start with confirmed coronavirus infections. We're going to report at least 2 codes. We're going to need one code to actually identify the infection, and then another code to describe what the specific infection is, and possibly additional codes for respiratory failure if that happens to be present. Of course, you're going to add other codes for other comorbid conditions that meet the conditions for reporting in addition to all of this. All right, so the new code, this is totally new for a new code to be released mid-year. We actually got 2 this year, but we have this new U code. We've created an entire new chapter and section and guidelines. So U07.1 as of April 1st is going to be your code specifically for the novel coronavirus 2019, otherwise known as COVID-19. This is going to be used as a principal or first listed diagnosis code, okay? Except there's always exceptions to everything in coding, isn't there? It's not going to supersede the usual guidelines for OB and newborns. So if you have an obstetric patient with COVID-19, you're still going to use a code from the OB section as your primary, followed by this U07. And same thing with newborns. All right, so here's the common things. COVID-19 is a respiratory disease. It is unique to the respiratory system thus far. So we've got the common coding scenarios that were outlined by the cooperating parties in the updated guidelines. So if you have pneumonia due to COVID-19, as of April 1st, we're going to put that U07, and then we're going to use an additional code for other viral pneumonia. Bronchitis, you're going to see a pattern start to emerge here. We're going to start with U07.1, and then we're going to add an additional code for either acute bronchitis, or if it hasn't been specified, or then we're going to use the J40. 2 codes. Lower respiratory infection is, again, our U07.1, followed by J22. So you notice this is an unspecified acute lower respiratory infection. Unspecified infection due to the COVID-19 is, say it with me now, you probably can all recite it with me, the U07.1 and the J98.8. Okay. There was a special note put in the guidelines. COVID-19 is always respiratory, so we're not going to be using B34.2 coronavirus unspecified. And I've done it again. We're not advancing there. There we go. Okay, so acute respiratory distress syndrome due to COVID-19. Again, U07.1 and J80. So the acute respiratory distress syndrome is different than the respiratory failure. Doesn't mean that the organs have completely, or that the lungs have completely shut down. It just means that we're requiring supplemental oxygen or intensified observation. Okay, so let's talk about how we're going to do that before April 1st, today. We're still going to use a code for the specific infection, your pneumonia, your bronchitis, respiratory infection, what have you. The secondary diagnosis code is going to be B9729, which is other coronavirus as the cause of diseases classified elsewhere. So prior, because they are not making that U07.1 retroactive before April 1st, and so the coding is just slightly different up to that point in time. But still 2 codes for everything. It's just the order's a little flip-flop there. In that case, your respiratory disease is going to come first, followed by this B9729. And as I just said, that doesn't count after April 1st, but I wanted to give you guys how we actually do it today for what, the next 6 days, 7 days. Okay, if you have acute respiratory failure with this particular disease, the guidelines that are already out there aren't going to change. So you can code respiratory failure as the principal diagnosis if that occasions the admission, if that meets the guidelines for the acute respiratory failure. Acute respiratory failure is still going to have to be coded as the secondary diagnosis if it doesn't meet the conditions for assignment as a first listed diagnosis or principal diagnosis. So basically, it's not changing what we've already known. You're referring to the guidelines that are in Section 1, subsection C, Chapter 10, subsection B of our coding guidelines. I would think in a lot of cases, acute respiratory failure is going to be your principal with this, but depends on your circumstances. Okay, this is pretty important, and this follows basically the guidelines for our other type of influenza stuff. Regardless of your setting of care, so be it inpatient or outpatient, if the physician documents suspected, possible, probable, we're not going to assign B97.29 or U07.1 after. It has to be actually confirmed, although it can be, I've got in another slide here, it could be a presumptive positive patient. But if we don't know, patient doesn't have at least presumptive positive test results, we're not going to code it as a COVID-19 active infection. Instead, you're going to go to whatever signs and symptoms the patient is having. Okay. It's an exception to the inpatient guidelines rule, but it is that way for some of the other infectious disease processes, the influenza in particular. All right, so exposure to COVID-19. They did not add particular additional ICD-10 codes for exposure to this specific virus, although they are talking about that to add in October. But right now, we're going to use the codes that are already there. So we have encounter for observation for suspected exposure that's been ruled out. So the patient is coming in because they thought they might have been exposed, but in the end, we really don't think they were exposed. That's Z03818. Or they are exposed. We know they are exposed. We're going to use Z20.828 for the contact with and exposure to viral communicable diseases. So not specific to this novel coronavirus, but that's what they want used for the time being. Okay, wanted to emphasize there again that B34.2 is not going to be appropriate because this is a respiratory illness, and so we're not going to use that unspecified code. All right, so that covers our diagnosis coding for this. Now let's talk about the new CPT and HCPCS codes for testing. I think it's absolutely wonderful that the AMA and CMS worked so quickly to create a new CPT code and new HCPCS codes. We find ourselves, though, in the situation that we sometimes do of which one in the world are we going to report and who wants which one. So I have been doing a little bit of research, looking at everything I can, because this is such an emerging crisis and we already have enough problems as we're going. Most insurances that I was able to find are accepting either the CPT code or the HCPCS codes. And what they're basically doing is modeling the ones that I could look at. Don't take this across the board because every payer is going to be different. But the ones that I found and saw, Humana was among them, Aetna was among them, Blue Cross, were modeling payment for this 87635, basically making it equivalent to payment for U0002, and we'll look at that in a little bit. But so far, it looks like you're going to be able to report either one when you do this testing. So here's our new CPT code. There's so many parentheses and brackets and stuff in here, but basically this is for the novel coronavirus, the COVID-19, when detected by nucleic acid, DNA, or RNA, which I believe is the only way this can be tested right now. So shouldn't be any worries there. And this code is effective on March 13th. The AMA also published a special edition of the CPT Assistant. So I copied a couple of the, I thought what would be the more interesting questions out of here. At the end of this presentation, you'll have the reference if you want to go out there and take a look at this for yourself. But I thought there were going to be some questions around this particular stuff. So basically one of the questions was, what if I have to do multiple separate specimens, separate being a key word, for this virus? And they are saying to report 87635 and another unit of 87635 with modifier 59 if you have to do multiples of those. Now, we haven't seen quite yet an MUE value on this, so I don't know what CMS is going to do for how many times this could be billed on a single day. So stay tuned for that. Of course, we'll make sure we update you on that kind of stuff. The second question was, what's the difference between this new 87635 and some of the other codes that already have coronavirus in their description? So basically the answer to that is the other codes that are existing for some of the coronavirus variants that were out there are all for multiple different viruses and pathogens. This one is unique to the COVID-19 and any pan-coronavirus types or subtypes. So if we see this thing mutate, but it's still a COVID-19 virus, 87635 is going to be your code when you're testing specifically for that. Okay, is 87635 required to be reported in conjunction with any other codes? And they say right now it does not require reporting of any additional CPT codes, and there shouldn't be any restrictions around reporting 87635 as a separate assay. Now, again, this is the AMA's guidance, and we don't yet have the procedure to procedure, the P2P guidelines from CMS, but right now there are no known restrictions. All right, so here's our new HCPCS codes. There are two of these. One for if the CDC performs the test, and that will be U0001. It's a lot of zeros. And one for any other tests, basically, that are not performed by the CDC. These do have different payment rates, and again, we'll take a look at that in a second. So one CPT code, regardless of basically who's doing the test, two HCPCS codes. All right, so looking at our new HCPCS codes, the differences, I wanted to put the differences in the things that are the same, basically, just so you can have a side-by-side comparison here. You'll notice that the reimbursement rate is different for these two things, and that's because they're expecting the non-CDC test to require supplies and materials that are not free. You know, the government basically gets them and there's no charge, which is why there's less payment for the CDC performed test. Both of them are effective February 4th, 2020, but this is important too. If you have these on any of your claims, hold your Medicare and the MACs are requesting that the claims be held until April 1st because they're not going to be ready to process them until April 1st. Of course, instead of holding them, you do have the option to actually submit them, but then you'd have to resubmit them for correction after April 1st. So your choice. And then last but not least, I wanted you to have access to where all of this official guidance, where all of my presentation came from, so that you can go out and take a look for it yourself if you'd like to do that. Do we have any questions on all of that?
Yes, we actually do. Thank you, Jennifer. That was extremely helpful and obviously very relevant in this day. So I will go ahead and start the Q&A portion of today's webinar. I want to remind you guys, again, if you have any questions from what Jennifer just presented, please feel free to enter your questions in the Zoom meeting chat area, and we will get to your questions as time permits. If we do not get to all of your questions by the 8 minutes that we have left of today's webinar, we will absolutely make sure that we include all questions and answers in an FAQ document and send it out to all the attendees for today's web session. So we'll go ahead.
I'm sorry, Julie, while we're there, did we want to mention that for the time being, the My Advisor questions are unlimited related to COVID-19 if they think of something afterwards and they're a VitalWare client?
Yes, absolutely. That's great. That's great to mention, Jennifer. If you are currently on today's session and you are a VitalWare client with knowledge, with vital knowledge, you have the opportunity to enter in as many questions within My Advisor regarding COVID-19 as you need, and we will get to those answers in a very timely fashion. So there's no limit to the questions around this topic within My Advisor. All right, first question, Jennifer. How would pneumonia in a patient with COVID-19 be coded? J12.89 other viral pneumonia, or J12.81 SARS-associated coronavirus pneumonia?
Well, and again, this is from, oops, what happened there? Huh. Can you guys still hear me?
We can still hear you.
That's bizarre, but the PowerPoint disappeared, huh? Or did it are you still seeing the PowerPoint, Julie?
I am not, but
I was going to say.
You know what?
Well, that's okay.
Yeah.
That's okay. I was just going to put it up there, what we had. We'll not do that anymore. Here we go. Let me do this. Okay. So the cooperating parties are recommending J12.89, and I believe the reason for that is the SARS, the J1281 that you have described, that's a different disease than COVID-19. It is a coronavirus, and it does have that in common, but it is not this COVID-19 virus, and they are trying very hard to keep track of these specific cases versus the anything that would be SARS related at this point. It's close, but it's not the same. This is technically the N-2019-SARS virus.
Okay, great. All right, next question. In the ER department, how do you code presumed COVID-19 if the test is not done for COVID-19?
If the test is not done, that would be a suspected, possible, probable. And in that case, you're not going to put, you're not going to code it as though it is COVID-19 until you at least get that presumptive positive test result back. And I know that there's a shortage of tests everywhere in this country, and there are a lot of people that are not being tested that we're even relatively certain have it. But unless they have that presumptive positive test result, you're not going to code it as a COVID-19. You're going to instead use whatever, if it's just signs and symptoms, which I assume it would be if we're not testing them, or bronchitis or whatever else they have.
Okay, great. How would you code patients with sepsis and COVID-19?
Well, we're not changing our underlying coding guidelines. So your sepsis criteria are going to remain the same. It depends on, whether or not that has been actually linked. And I'm looking right now through all of my Q&A that came with this, just to make sure. I'm going to have to do a little additional research on that, because something in the back of my head is pinging me that maybe they did actually address that, they being the cooperating parties that published the official Q&A on this.
Okay, great.
But
So
let
we'll
me get back on
definitely,
that. Yeah, I don't want to give any
right.
incorrect information. So
We'll definitely include that question and answer within the FAQ document we send out. Next question, would we use the B code for other strains of coronavirus that the patient may test positive for with acute bronchitis?
Well, I think that question's asking if they were to come in and they didn't have COVID-19, but they had a different coronavirus, then you're actually going to use, the code for that other coronavirus, like that previous question was for J1281, which would be for SARS coronavirus. So yeah, if they happen to test positive for something that's not COVID-19, nothing's going to change. You're still going to code that the way you would have.
Okay, great. This is an interesting question. If the CDC and the public health labs run the tests at no cost, then why is there a payment from CMS?
Yeah, that is a good question. And again, there was something in one of these. Is it totally no cost to the facility? I'd probably need to talk to some hospitals on that. Or my understanding is what they're reimbursing for is the fact that the hospital is still having to collect the specimen, which is going to take some minor supplies. You're still having to get it out to the CDC, but that is why the reimbursement rate is, it's not quite half, but it's a little more than half of what you get if the test is done non-CDC, but that's why there's lesser reimbursement.
Okay, gotcha. Okay, so what is the difference between U0002 and 87635?
Not much. It's just that CMS created one code and the AMA created one code. That's why I said it's great that they all jumped on this as quickly as they did, but whenever there's a HICS and a CPT code that basically say the same thing, it's always confusing to know which one to use. And I believe that's why every payer I was able to research is taking either of them.
Okay, great. This will be the last question. And again, have no fear, those that submitted a question and we were not able to get to it within the live webinar today, we're definitely going to include all questions within an FAQ document as well as the answers for each and send it out to all of you attendees, in addition to a copy of today's presentation and a link to the live recording so you can share it with your coworkers. All right, last question, Jennifer. Mm-hmm. If a patient came in with bronchitis and has been around sick people not documented as having COVID-19 and testing was done, which came back negative, which codes would I use?
Okay, well, in that case, based on the scenario you gave, we have a negative test, so we can't code it as a COVID. I would go and use the code for I assume it's acute bronchitis. And then you would probably want to add on to that the contact with and suspected exposure to other viral communicable diseases in order to be able to track that. But we can't, unless you have a positive result, you can't code them as COVID-19. So 2 codes in that case, the code for the bronchitis as well as a code for contact to other viral communicable diseases.
All right. Okay, so again, we're being very time sensitive. We know everyone has a lot on their plate right now. So we're going to go ahead and wrap up this live webinar. I want to let you know that we will be sending you a link to complete a very short 3-question survey once we wrap the session. We ask that you please take 2 minutes to complete the survey, as this is the only way we're able to measure the effectiveness of the content we presented. So thank you in advance for taking the time to offer your feedback. We greatly appreciate it. And as mentioned earlier, we'll be sending an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented and a link to the live recording within 5 business days. So we'll be within an email. If you'd like more information on what you saw today and you're a current VitalWare client, please reach out to your account manager. And again, please feel free, if you are a current Vital Knowledge client, go into my advisor and ask any questions you would like around COVID-19, and we will get to those in a very timely manner. To stay up to date on VitalWare's future webinars, we invite you to follow us on LinkedIn and check out the upcoming webinars on our website under the reference tab. So again, thank you for joining us today. We hope everyone stays very well and healthy. And we are offering the same webinar next Thursday, March 31st. If you would like to attend again, and or if you would like to share it with some of the others in your organization. So thank you again for joining us. Thank you, Jennifer, as always. Great job. Have a great rest of your day, everyone.
Right. Bye, everyone.